Assalamu alaikum. I'm Professor Sadia Ehsan Pal. I'm a consultant gynecologist uh, from Karachi, and I am an executive member of the Society of Obs and Gynae of Pakistan, as well as a vice president of AMAN, Association for Mothers and Newborn. I welcome you to this webinar today. Basically, we will be discussing the myths and misconceptions which are circulating around the HPV vaccination introduction in Pakistan very soon. I have an eminent group of panelists today who will be addressing these questions. And our first panelist is Professor Azizul Nisa, who is uh, the president of Society of Obs and Gynae of Pakistan and also a member of NITAG. The other panelist is Dr. Khalid Shafi, who is a very senior member of the Pakistan Pediatric Association and also the chairperson of NITAG in Pakistan. Then we have Professor Tasneem Ashraf from Quetta, Balochistan. She is the former president of the Society of Obs and Gynae of Pakistan and has done immense work on cervical cancer when she was herself president. Then we have Dr. Professor Aisha Siddiqa, who is the president-elect of Society of Obs and Gynae of Pakistan, as well as a council member of the College of Physicians and Surgeons of Pakistan. And we will be asking her about the future that SOGP is going to take, the actions that she's going to be taking. Then we have Dr. Azra Ehsan, who is the president of AMAN and the vice president of NCMNH, and Dr. Razia Kurejo, who is the former president of SOGP, Professor Batul Mazhar, who is also a very senior member of SOGP and president of SAFOMS. Professor Jahanara Ainuddin, she is the professor of Obs and Gynae at Dow University, Karachi, and she's also its vice chancellor. Then we have Professor Alia Begum. She is a consultant obstetrician and gynecologist and radiation and gynae oncologist at the Al Khan University Hospital, as well as being a senior member of the Society of Obs and Gynae of Pakistan. And Professor Aisha Malik, who is professor of Fatma Jinnah Medical College, Lahore, and also a senior member, executive member of the Society of Obs and Gynae of Pakistan. So we will be starting with questions addressed first to Professor Azizul Nisa and then to Professor Khalid Shafi. Professor Azizul Nisa, what can SOGP, as the premier professional body of gynecologists of Pakistan, do to encourage HPV vaccination and regular cervical cancer screening?
Assalamu alaikum. I'm Professor Azizul Nisa Abbasi. Thanks to the organizer for inviting me. I really feel honored to be part of this great activity today. Being SOGP president, I was the member of the NETAG, and we have attended many meetings online and also in person. And in each meeting, I advocated for inclusion of EPI vaccine, HPV vaccine in EPI schedule. And thanks to Allah and congratulations to all of us that ultimately the program has kicked off. Initially, it will be pilot program in some of the provinces, and later on in 1 to 2 years there will be 100% coverage all over Pakistan. Actually, this vaccine is will be given in a single dose, and it will be administered to the girls between 9 and 14 years of age, and it will be available in the EPI centers as well and they're going to do this vaccination in the school as well. So as an OBGYN, it's our duty to encourage people, and especially the mothers, to have their girls vaccinated. And SOGPs can be a great platform for this dissemination program, awareness programs. SOGP, we have 32 chapters all over Pakistan, and we can ask our chapter chairs and their executive council to do these awareness programs in their vicinity, in their area, and they can go to the schools for advocacy, for administration of this program. And as we all are practicing OBGYN, so every mother coming to the antenatal clinic or the gyne clinic, it hardly takes 1 minute to talk about HPV vaccine. And we can tell them that if you have a girl 9 and 14 years old, you do get her vaccinated with HPV. Initially, many people are saying that disease burden in Pakistan is very low, but as it is a life-threatening condition, the cause is known and vaccine is available, so we should go for that. Even 1 or 2 deaths are avoided, that will be great achievement. And I think there are only 2 feasible methods for prevention of cervix in Pakistan. One is vaccination of the girls, and second is screening for precancerous condition and treatment of precancerous condition, VIN, CIN, lesions. And we should all be doing, as WHO has proposed, VIA screening for low resource countries, and that is very suitable for us. And for the last 2-3 years, I am advocating for having VIA screening by all of us all over Pakistan. It's very easy to do. And VIA screening, what we are doing here in Aptabad districts and Zara division, what we do, we stain the cervix with 2% acetic acid. And many people say where to get acetic acid. Acetic acid is white vinegar. It is usually 4.5%. To make it to, we can dilute it with 50% water, and when we can use it. And for aceto, what to do for aceto white areas? If colposcopic facilities are available, we can do colposcopy and take biopsy. And if colposcopy is not available, just do deep diathermy. And diathermy, I think it is low cost and it is available everywhere. So do deep diathermy and then send them home and ask the patient to come for follow-up after 6 months. So these are the 2 methods by which we can reduce the incidence of CS cervix, and inshallah we will be successful in doing that. Once again, thanks to everyone for patient listening. Thank you.
Professor Khalid Shafi. After the initial HPV vaccine launch in EPI schedule, can pediatricians successfully maintain the momentum and incorporate a single-dose HPV vaccine in their practice for girls?
Okay, doctor, that's a very good question. There are 2 answers to this question. Pediatricians are the one, in fact, who are doing the vaccination because in our country, the vaccines are only given in the childhood age or to the pregnant ladies. They are used to give vaccine, advocacy of them. So that is one aspect. And many of the pediatricians even now have included in their card about this cervical vaccine. Even in my card, this is mentioned for the last 5-6 years. And people keep asking, what is this vaccine now? The fact is that the pediatricians will include. There is another answer to this. What strange response I have got from a segment of the pediatricians about the opposition of this vaccine. They were saying that first we will improve our vaccine coverage with the present vaccine, then we include any new vaccine. So it has been discussed in our many seminars, symposia, even some legion type of the people are against inclusion of new vaccine. But in fact, we a large proportion of pediatricians are in favor of vaccine. Not the NITAC has a very clear vision. Not this vaccine. We want life course vaccination approach in our country The vaccines are not to be limited to the children. Of course, the vaccine coverage should be improved. Vaccines are more important in the childhood, but the other segments of the society should also receive the vaccine. So hopefully, we will educate this vaccine and we will include in vaccination program because the client age is of the pediatric age, and we'll make our pediatricians to educate all the parents that after the 15 months MMR and other the booster, we will tell them there is another vaccine which will be given to the female child at 9 years of age. Thank you.
Thank you, Dr. Khalid. I know it's a very busy time for you. So panelists, Professor Aisha Siddiqa, she's our president-elect of SOGP. So Dr. Aisha, you have a very special role as the next president. Actually, you are the next president, already elected. How do you plan to take it forward? This campaign, both on the platform of SOGP and as well as the College of Physicians and Surgeons. Do you think trainings can be incorporated, or OSCE examinations? So would be happy to hear from you.
Thank you very much, Dr. Sadia. It's really an honor to be the part of this important webinar. And I'm very grateful that today we are talking about this important topic. And as I have been asked about the role of SOGP and CPSP, as we all know that cervical cancer is one of that cancer which is preventable. And as Professor Azizunisa very well said, that the only two proven strategies are regular screening and the HPV vaccination. As a next president of SOGP, my plan is that as SOGP has got a reach to gynecologists all over the country, even I will say that outside Pakistan, even we have our chapters. We can mobilize our gynecologists. They can help in creating awareness amongst the healthcare providers, among the communities, and SOGP is the platform where we can provide training, because the main problem is of the training. When I was a postgraduate in Royal Infirmary right back in 1994, my consultant, Professor Kennedy in Royal Infirmary Hospital, at that time was practicing LLETZ. He was using colposcopy to diagnose pre-malignant and all these conditions. Why not we from the platform of SOGP? I think it's the time that SOGP can develop Pakistan-specific guidelines. We are following the Western countries. It's very true that the burden of disease is not that much, as I saw in Glasgow, in UK and Europe. But the thing is that this disease has to be prevented, and we have to protect our mother. Why not SOG from the platform of SOGP, we develop Pakistan-specific guidelines, and we provide like TOT trainings, how to perform a proper pap smear, how to perform VEA, how to do a colposcope, LLETZ, punch biopsy, and all these things. We can conduct seminars, and we can do hand-on trainings. There are so many pharmaceuticals who are approaching us for these training. Now, talking about College of Physicians and Surgeons of Pakistan, as we know that CPSP has got its role in capacity building and standardization. By incorporating the cervical screening program, colposcopy, HPV vaccination strategies in our postgraduate trainings, as well as in our exams, because we know that now extended talks. So I would like to emphasize that in FCPS Part 2 exam, in MCPS and IMM, there should be a station which should be specific how to take pap smear, how to perform VIA, how to perform colposcopy. And this station should be mandatory. And I think that SOGP, by fostering the research by encouraging the students to write synopses and research papers on this topic. And a CPSP, by its training, by its trainees, by supervisors, by its fellows, can provide the evidence-based information, and then the policymakers can be guided that this is the real burden of the disease, and how can we guide the policymakers, the Ministry of Health, the Provincial Health Department, and all these. I think if both of these professional bodies can join together, then I must say that it's not a disease, it's not a distant dream. It is a preventable disease. If both of these bodies, they work together, then we can prevent. Thank you very much. Thank you.
Thank you so much, Dr. Aisha, Professor Aisha. It's really heartening to hear your plans as the future president of SOGP. Let me just share with you about the Teal Ribbon Alliance. When we formulated it, we had the advocacy meeting in Karachi in 2015, and it's sad because on that day, Shireen Bhutta was there. She was the vice president of SOGP at that time. And we had this, and we actually we had drawn up as a professional body the guidelines for cervical cancer prevention. So these guidelines were not very different from what now the WHO is recommending. In fact, we had a press release, and at that time, Professor Tasneem Ashraf was president, and Professor Sadka Jaffrey was president, still is president of NCMNH, and Dr. Shahida Zaidi was president of AMAN. So that document was signed by all three, and it is on the website of both SOGP, AMAN, and NCMNH. So it has been updated according to the slight changes because of the single dose vaccine. And I would like to share that the inclusion of this vaccine in the EPI is like a dream come true for us and the pediatricians as well, because this is one of the things we were recommending, that it should be available free, because the most women who are most at risk are those disenfranchised women and those who don't have the means to even visit a doctor. So I'm very happy that you have these plans. And I will also share here that in Pakistan, the LETs instruments, the loops, the insulated Cusco speculum with smoke extractor, all these things are made in Pakistan, but they're not marketed here, and it's a shame. So I think, inshallah, when SOGP takes it up under your leadership, we should ensure that every gyne setup in Pakistan has these instruments as well, so that outpatient loop excision, LETs treatment can be carried out. Now, I will now address my next question to Professor Tasneem Ashraf. I've already mentioned her. She has been an amazing support for this campaign. And I remember working with her a lot when I was vice president in my tenure, and she was working on this very topic. So, Dr. Tasneem, how can gynecologists ensure that pap smear or VIA becomes a part of routine gynae practice? In the absence of universal pap smear screening, is VIA a practical option for screening in Pakistan?
Bismillahirrahmanirrahim. Assalamu alaikum, everybody. Thank you, Sadia, for very kind words. And thank you for having me here on this very important forum, a webinar about the cervical cancer prevention awareness. Your question is very good and pertinent and relevant, that whether the gynecologists they can ensure pap smear or VIA test in routine gyne practice. As we know that HPV vaccination inclusion in the EPI program does not decrease the importance of cervical cancer screening. So it is the personal will and determination of the doctors and the gynecologists, and at the same time SOGP guidelines and the CPSP endorsement is very, very important to bring all the gynecologists on the same platform. For that, we need certain training programs, especially the training of the gynecologist and the mid-level healthcare workers. They can be trained about this pap smear and VIA test. And that these are not very difficult tests. If we are doing regular workshops and training, we can train them, and we can have we can have these screening tests in all sort of OPDs like gyne OPDs, family planning, and the postnatal clinics. Capacity building of the junior doctors can be done by organizing workshops from the platform of PSP or from the SOGP platform. At the same time, we need to educate the patients and make them aware about the importance of cervical cancer screening. So any woman who is presenting between the age of 30 to 65 to the OPDs for any problem, they should be offered and counseled for any for cervical cancer screening by pap smear or by VIA test. And that we are already doing at our institution. Personally, many of my colleagues are doing over here in Quetta and in both the hospitals. At the same time, for these programs, we need institutional support as well. Like we need advocacy of the MS or the head of any hospitals to provide the items for this pap smear or for acetic acid as a routine supply in OPDs, because we can't arrange these things personally. So these things should be provided by the MS of the hospitals. That can motivate. And at the same time, we need to build partnership with the pathology lab, because while we are sending pap smear, we are not getting the report well in time. So we must have a liaison with the pathology lab, and there should be some method for documentation of these screening program, and audit of this data should be done in order to be utilized later on for further improvement. Regarding your second question, that is in the absence of universal pap smear screening, is VIA a practical option for screening? I would say yes. And because it is a very safe, low cost, quick test, and it doesn't need any laboratory, can be performed by the mid-level healthcare provider. Any person can do it. Like nurses, midwives, or junior doctors, if they are well trained and they are having regular training, they can do it. And the best advantage of this method is that at the same sitting, you can examine the patient, and patient can be treated like cauterization or colposcopy is available in our setup over here. That can be done easily at the same time. So the best VIA is the best option for the low resource countries like Pakistan. It has very good sensitivity and specificity. But the challenges are that we need regular training and supervision in order to standardize the procedure. And if it is not standardized, that can lead to treatment of false positive cases. and that can lead to overtreatment. At the same time, we would request that VR test or pap smear should be included in the National Health Program for its sustainability. And that's all.
Thank you so much, Dr. Tasneem. That was very comprehensive, and I know about your previous work. And inshallah, we will keep bugging you to assist us in the future as well.
Inshallah.
So thank you for sharing your. My next question is to Dr. Azra Ehsan, who is President of AMAN. Dr. Azra, how safe is the vaccine? Are there any serious side effects? Can it cause infertility? What queries are being faced in the community regarding HPV vaccine?
So we all know that this vaccine has been rolled out in almost 150 countries and more for the past 20 years. And no serious side effects have been reported, mild side effects like pain and redness and swelling at the injection site, but nothing more. So it is more than 22 million doses. That is what WHO has reported in 2022. So no serious side effects have been reported. It is an extremely safe and effective vaccine. And for all vaccines in Pakistan, the fear starts that it will cause infertility. And that is, has been said about polio vaccine. And look at polio vaccine, how many decades it's been in use in Pakistan. And yet Pakistan is the 5th most populous country in the world. So it has certainly not, caused any infertility. We are, reproducing like nobody's business. So this vaccine also has no such effect. It has no effect on the fertility of the girls and women, and it is extremely safe. And yes, AMAN, Association for Mothers and Newborns, is now working on a project, on an advocacy project, and we have been going into the communities. We've been interacting with teachers. We have been interacting with young girls and their caregivers, parents, and grandparents. And all these questions, like you just asked me, are being asked from them. They're also asking why the boys are not getting this vaccine and why the older girls are not getting this vaccine, why only 9 to 14. So we have to reply to all these questions.
So can you give the answer?
Yeah, so the answer to this is why 9 to 14-year girls are being, the first cohort that is being addressed is because in this age group, the immune response is excellent. And, we have to catch these girls not only for this reason, but before they get married in Pakistan. We know child marriage is fairly common in Pakistan. Girls, the parents want to get their girls married. As soon as these girls have their first periods, they're worried and they want to get them married. So before any exposure to HPV, it is best to get these girls vaccinated. We all know Pakistan is a resource constrained country. So because of the resources, the limited resources that we have, 9 to 14-year-old girls are the first cohort. But older girls and boys, hopefully our country would get enough resources and you'll be able to immunize them too.
Okay. Thank you, Dr. Azra, because I will be now addressing to take this further, Professor Batul Mazhar. I think she is there online. So, Professor Batul, how can we dispel myths surrounding vaccination in our society? Is a single intramuscular dose enough for protection? Because previously we were giving 3 shots when this vaccination started almost 20 years ago. And then it came down to 2 shots. And now we are down to 1 shot. And can older married women and boys also benefit from the HPV vaccine?
I think very important question of myths, because that is the biggest worry in Pakistan, because we faced that in polio vaccine, and
it was very nicely answered by Dr. Khalid that we had worries about polio vaccine, that it is going to cause infertility in our population. But we have continued to grow far ahead of all our neighbors. So majority of people can be reassured that these vaccines are basically to save lives, and especially with the HPV vaccine, we have to lead with very clear messages, with very, very repeated and clear and similar messages. These should be brief, these should be very affirmative, like you say, HPV vaccine prevents cancer and is very safe. Now, this is a very simple statement, and whatever query comes, we can always respond. But the primary message is this is a vaccine to prevent cancer, it's very safe, and it is the teachers, it is the clinicians, it is the community leaders, the religious leaders. We all need to have a uniform message. School-based sessions are extremely important. FAQs need to be shared. And I think I'm sure you're aware of it, that very simple leaflets have been shared, simple FAQs have been made, and they're very much available. So I think the social media helps. Many schools have made WhatsApp groups. And very important way to answer a particular myth is that you address it by giving the right message. You say it doesn't cause infertility, or it doesn't lead to promiscuity, or it has been proven safe. So you say that, then you say this is the myth, and then you just repeat that message. So that helps with the sandwich technique, helps you to do that. And the social behavior change, these tools which we use for the social media messages, the video that I'm sure you'll share, the video that has been made is very, very simple, pictorial, understandable, and all people can really understand it. Then we come on to actually the cancer prevention impact. This is the most important, because I think this is the dream of every clinician, that there would be primary prevention of cancer. We've already seen secondary prevention. It has happened in majority of countries, and over the past 20 years that primary prevention has kicked in. And in Denmark, recently we had a gentleman from Japaigo, a very senior person, and he told us that Australia is going to be cervical cancer free from next year. Denmark is less than 2% possibility of getting, a non-immune status. So they are approaching the excellent levels that are the dream that we are starting on 20 years later. Let's not stop. Let's have at least 70% of our eligible girls vaccinated. Now I'll come on to the single intramuscular dose bit. As you very rightly said, currently in USA, still they have the 2-dose in majority of developed countries, but WHO 2022 statement position paper endorses a single dose schedule. So we are following a WHO recommended schedule. It has been tried in countries like Kenya, Nigeria, and in Costa Rica. There are countries which have found excellent results and prolonged immunity with even single dose. So 10 to 12 years ahead, you're still looking into immunity, and that is where you expect the girls to be entering into their reproductive lifespan. So that is very important, but once the girls are beyond 15 years of age, you will need 2 doses. The 9 to 14 is a fantastic age where they are very good immunogenic response, and 1 dose is good enough. But if you give it to girls who are beyond 15, you'll need 2 doses, and same would be true for the older women. The 3-dose schedule comes for people who are immunocompromised, the HIV positive, who are more likely to get cervical cancer. So 1 dose, it is WHO has basically recommended it in the position paper. It has already been tried. When 150 countries are going to do it, includes very close Islamic brethren countries like Indonesia, Malaysia, Saudi Arabia, Qatar, and we are part of the same area, part of the same culture, part of the same religion, and I think we should be looking forward to a very good outcome in our girls as this cohort starts growing older. No boosters are required. You do not need a booster with the single dose in 9 to 14 years. At present, whatever knowledge we have, which is for the past 20, 25 years. Now, talking about whether older married women, whether they should have it, yes, up to 26 years of age, we do recommend it. But even beyond that, it is of use. It may not give immunity if they have caught one or two of the HPV viruses, but it would definitely give a 50 to 60% immunity compared to more than 90% immunity we are expecting if we give it in the younger age group. So benefit is individualized. The efficacy is anywhere between 40 to 88%. So boys and men, again, countries like Australia and other European and developed countries have started vaccinating their males. It is great. We look forward to that time. Let's welcome it for the females. And I'm sure as we get good results, good response from the community, it will come when it becomes commercially available, when it is with cost. Now this is free of cost. Again, remember, the country and the Ministry of Health are bearing the cost. It is not free. Nothing is free in the world. This is borne by the government of Pakistan, by the various Gavi who are helping us. So please remember, this is free vaccine with excellent results. Please use it to the max, and let's look forward to a cancer-free Pakistan, maybe in 20 years, maybe in 10 years, as we have the pap smear and other screening possibilities as well. Thank you, Sadia.
Thank you, Dr. Batul. So let's not forget that it's the taxpayers as well who are funding it. And we're very happy that the government is funding it. So the other thing which I just want to point out is 75 countries are now using the single dose. And there are over 150 countries in the world which have implemented this vaccine. So we're not the only ones, and the single dose, as Batul, you mentioned, is as effective. It doesn't matter which vaccine is being used, whether it's the bivalent, quadrivalent, or the nonavalent. Regardless of which vaccine is being used in whichever country, there is enough data showing that they are equally effective. Okay, so that I just wanted to share that because a lot of people may not know that. Now, my next question is to Professor Jahanara Anuddin, who is Vice Chancellor at Dow University and very senior and a professor of gyne-obs there as well. Professor Jahanara, I know that you've been involved in this at Dow University. A cancer registry in Pakistan remains a challenge. What efforts are afoot that you know of to establish this? And should all medical and nursing students be trained in cervical cancer screening methods before they graduate?
Thank you, Dr. Sadia. Cancer registry in Pakistan is definitely a big challenge. There are more than 17 existing cancer registries as per a study done in Lancet. These are fragmented data systems which are operating usually in hospitals, like in Karachi, the Karachi Cancer Registry, the Health Research Institute related cancer registry, the Aga Khan University Hospital Cancer Registry. These are all cancer registries which are operating in Pakistan, but they are only focusing in the hospitals and only the urban population. The challenge is there are inconsistent methods of assessing them, and there's a poor rural coverage related to these cancer registries. So there's a need for a unified cancer registry which works in a coordinated system and usually in a way that it's easy to enter the data, collect and integrate and regulate the data. There's a dire need for a government-led national cancer registry, which is both necessary and is achievable if we do a proper planning and the funding is there and integration of all these cancer registry. The integration is only possible if the academic institution, the government bodies and the public-private partnerships are there, like people like you who can integrate and help in formulation of this registry. The registry need to be linked to NADRA for accurate patient tracking and giving the patients a unique identifier number like related to their national identity card, the ID card numbers. It's easy to track and see the pattern of cancer in Pakistan. So this national level cancer registry is important, and we can benchmark our model with the cancer registries like NCRP in India and CIA in US. So there are registries and we can benchmark them. We can adopt a model like this. We can formulate and we can customize a model which is viable for Pakistan. So it's possible. We are trying to train cancer data operators who can enter the cancer data in a unified manner so that a registry can be established in Pakistan.
Thank you, Professor Jahanara. Day before yesterday, we had this news clip. I don't know, I hope it's true, that the President of Pakistan has signed documents to start a cancer registry in Pakistan. So that's amazing, and I hope it happens soon. The other thing I would like to share is that SOGP also has done a lot of work, and that happened during COVID. And the Academic Council of SOGP had a gyne oncology group as well. I was there, and so was Dr. Alia Begum, and Professor Tasneem Ashraf was also part of it, from all 4 provinces. And that online registry, very much on the pattern of the diabetes and the orthopedic organization of Pakistan. They actually helped us and egged us on, and with some public-private partnership, that is all ready, and it's going to be, well, it's going through initial testing, but lots of hurdles about patient confidentiality, especially in the private hospitals. So, but we're working on it, and inshallah, that's some good news. I'll move on to Professor Alia Begum, and who is very well known in Karachi, at least, in Aga Khan University. Dr. Alia, what is the cost of a radical hysterectomy and radiation therapy in a private hospital, whether it's AKU or any other private hospital in Pakistan? We know the cost is similar. And can HPV self-testing kits be successfully used in Pakistan?
Thank you, Sadia, for a very good question. When we are talking about cervical cancer prevention, this cost is very important because our patients have to bear out of pocket. We don't have any national system supporting our patients. So I got the financial analysis out of my radiation oncologist, and according to him, a case of advanced stage cervical cancer who needs combination of chemo and radiation, the radiation only will cost about 16,35,000 in Aga Khan University Hospital, which is a private hospital. And same true for the surgery. So a radical hysterectomy, I took the values out for the last patient I did last week, and it cost about 9 lakh rupees. Sometimes we do have welfare available for poor patients or non-affording patients, which is both zakat and non-zakat. So the last patient I did was a very young patient, 30-year-old, who had renal transplant, and because of the low immunity, she developed first VIN. She had a simple valvectomy for that, and now she developed squamous cell carcinoma of the cervix. Luckily, it was early stage disease. She came because she was coming for follow-up. So it was caught early, and she is now probably cured by the radical hysterectomy, but it cost 9 lakh rupees. which was partly funded by the welfare department. So she had to pay only 50% of it. But you can imagine, even 5 lakh rupees is quite a bit for a middle class or upper middle class person to bear for the cost. But if you go for CCRT, it is more than double the cost. So it's about 20 lakhs for a total cost of radiation in a private hospital along with chemotherapy. I don't know about the public sector hospital. Maybe my colleagues from public sector hospital can provide some insight into it. I'm sure it is causing a little less, but the problem is that for the treatment, the brachytherapy is very important. It has to be given timely. And if it is not given timely, the treatment is not effective. And mostly in the public sector hospitals, the brachytherapy machine is out of order. And many patients, they come and they say that we were not given that treatment on time because the machine was not working. Plus, there is a big waiting list. So the patients who are waiting for the radiation in the public sector hospital, they sometimes have to wait for so long that their stages are progressed. So these are all the problems we are facing in terms of treatment of cervical cancer. The second question.
Thank you, Dr. Alia.
Yeah, second question, Sadia, you asked about
detailed,
HPV self-testing. In terms of HPV self-testing, there are two components of it. One is the technical part. Can our women do it? Yes, it is very simple. And we have been doing a study in which we are asking our women to do a HPV self-testing, and we are comparing it with the physician taking samples. So my experience is it's very easy, and people even from low educated community can easily do it. The second is the cost. So the cost is probably again unbearable by the low socioeconomic status women, and that will be one thing. So if the government is funding the self-testing kits, then yes, it can be done. The benefit would be the kits can be given to people who are living in remote areas, in hilly areas, and if our LHVs or some healthcare workers can give these kits to women who cannot access the healthcare units, then the women can take that sample, and those samples can be transported to the labs within 30 days. So you do have the 30 days timeline, which is again a good thing, but the cost is something which is a main concern.
Thank you, Dr. Alia. And perhaps we should now wait for cheaper HPV self-testing kits. And I think maybe we could also train our lady health workers who are doing so much work in the community. Maybe they could be also trained, and they could assist these our women who don't leave their house also in self-testing. I would just like to add to your the cost issue. I think the radical hysterectomy or even the radiation therapy that occurs in government hospitals actually costs a lot more than a private hospital. It's not free. There's, it is being funded by the government, and the government gets its money from the taxpayers again. And when I think we should audit how much it costs from the government hospitals as well. And I'm sure the cost will be a lot more. That's the reason why the National Health Service in UK, why they went towards prevention is because it costs so much to have these procedures, the radical hysterectomy or even a simple hysterectomy. So the screening, and I mean, it's a no-brainer. Like they say, prevention is better than cure. So we're waking up a bit late. Thank you so much. Are there any questions in the chat box, Humera?
So yes, Dr. Sadia, there are a few questions. So one comment is pap smear facility not available to majority of Pakistan hospitals. So which is very cheap. Why introduce expensive vaccines in Pakistan?
Okay, so whoever asked that question, pap smears are not cheap. They're expensive. And On the other hand, VIA or visual inspection of acetic acid may be a cheaper option where you can see and treat, as all the other eminent panelists have commented. So expensive vaccine? No. This is not an expensive vaccine. When you consider the cost, you just heard of a hysterectomy, a radical hysterectomy, and radiation therapy. It's nothing, it's peanuts. Do you know the cost of the vaccine when we started, when we had it in a private setup in Pakistan? It was 4,700 per shot, and we were 3 shots. This was all private, not government funded. The vaccines are a lot cheaper now. The bivalent vaccine that we're going for, it's WHO recommended and tested. And I think it's probably costs less than 1,000 rupees or around that much. I think it's a no-brainer. Would you rather pay 15 lakhs for radiation therapy or around 9 or 10 lakhs for, that's my answer to that. And I think our time is also up. So we will share this on our Facebook page, the recording of this. And we will, if you have the questions that are in the chat box, we will answer them on the Facebook page as well. Thank you very much, all the panelists.